Okay, so I'm gonna do trauma tonight and then medical tomorrow because I am very tired. So basically, this is the trauma assessment station. So first thing I do, there's 6 main things to do for the scene size up. First is BSI, scene safe. Second is determine the mechanism of injury. In this case, it could be a car accident. The third is to determine the number of patients. There's just gonna be one here. And then I'm gonna request additional EMS assistance if needed. And then I'm gonna consider stabilization of the cervical spine. It's pretty crucial for here as opposed to medical because they probably, if they're in a car accident, there's a chance that they've injured their spinal cord. Okay, that was scene size up. Now primary survey and resuscitation. So general impression of the patient, they're unconscious. The level of consciousness, so A, they're not alert. V, they're not responding to verbal, they're unconscious. P, they're not gonna respond to pain if they're unconscious. They're U, they're unconscious. Life threats and chief complaint, a key thing here is if there's major bleeding. So in this case, we're gonna say no major bleeding. I guess in this case, there isn't any. So that kind of saves us some things. So we could let's do circulation first for the ABCs. So we're gonna check their pulse and unconscious. You could do the carotid artery and make sure, look at the temperature then of their skin. Yeah, temperature or color of the skin. In this case, it's warm. Then kind of look at the bleeding, just like, okay, there's no major bleeding, so I don't have to control for that. And then initiate shock management, so like put a blanket on the patient, but if they're not in shock, then you can say, well, no need for a blanket. Okay, so that was circulation. Airway, so open and assess airway. So if they're like, if you look at their airway and say, okay, their airway's open, we don't need an adjunct, that's 2 points. Breathing, so assess breathing, no injuries causing issue with breathing. This step I actually have a question about because you might need to get an assistant to, for instance, apply, throw on an O2 mask at 10 liters per minute. So I'm going to I'm going to think about the breathing right there, but they might be breathing, so then we could say that, well, there's no injury that's compromising their breathing. Then the next part, which I kind of skipped the first during class earlier, was very important actually. It's to identify the patient priority and make treatment transport decision. And so I'm going to say they are a high priority patient. We need lights and sirens, we need rapid transport. There was that. So then history taking involves a first set of baseline vitals. We're gonna do blood pressure, pulse. We're also gonna, so for pulse, we're gonna look at the rate, then we're gonna look at whether it's irregular and regular, so the quality essentially, whether it's regular or irregular, strong or weak, and same with the breathing, so for respiration. So we're gonna look at respiratory rate and then respiratory quality, so are the breaths strong or weak, regular or irregular, all that stuff. And then we're gonna attempt to obtain sample history. But in this case, we're not gonna be able to because they're unconscious and can't respond to any questions. So we would say, okay, is there a bystander around that could tell me the sample history about the patient? And there's not gonna be, so we still get the point for attempting. Okay, so next part is the secondary assessment. So here we go with secondary assessment. So head, so we're gonna inspect and palpate scalp and ears. Then we're gonna assess the eyes for reactivity to light, and then pupil equalness, things like that. Inspect the mouth, nose, and facial area. In the neck, we're gonna look at the position of the trachea. We're gonna check the jugular veins, and then we're gonna palpate the cervical spine, and it will be pretty obvious if there's a really major injury there. It won't be stable. Okay, so chest and lungs, we'll inspect the chest, we'll palpate, and then we'll auscultate. I don't know if I'm pronouncing that right, but it's basically just listening for lung and chest sounds with the stethoscope back there. So then abdomen and pelvis, so there are 4 quadrants of the abdomen that we're gonna be palpating and inspecting. And like if we find distension, that might be an indication of internal bleeding, which is a pretty serious issue. Then we're gonna assess the pelvis just by pushing on it. And again, it will be kind of obvious if it's not in place and if it needs pelvic stabilization. Then we're going to just verbalize that we'd assess the genitalia. Lower and upper extremities, so we would inspect, palpate, and assess motor, sensory, and distal circulation function. So this is our CMS acronym. However, we can't really do motor and sensory because motor is asking the patient to wiggle their fingers, and if they're not conscious, they're not going to be able to respond or do what we're asking. And sensory is like, hey, which finger am I touching? They won't be able to do that either. So basically, we're only going to be able to get their circulation. And with the upper extremities, we're going to do their radial, and then lower, we're going to do their pedal arteries. So, okay, so next part is just the posterior thorax, lumbar, and buttocks. So we're going to inspect and palpate those 3 areas. We might have like the patient roll onto their side, but yeah. And then we're going to manage secondary injuries and wounds appropriately. So we might say like, I don't know, like, can someone just get some gauze and stop the bleeding from the shoulder? Okay, and then so reassessment. So we have to demonstrate how and when to reassess the patient. So we're going to take another set of vitals every 5 minutes since they're unstable. So we would do blood pressure again, we would do pulse, and we would do respiratory. And so based on the first set of vitals, like say for instance that the respiratory rate was like 28, well, that is above the respiratory range of 8 to 24, which, like above 24, you should ventilate with a bag valve for this unconscious patient. So say we check again and it's back down to 20, we might be able to say, okay, like we don't have to person 2 or person helper, whatever, stop ventilating. So that would be trauma, and I think that's all I'm going to do tonight.